Sorry.
Either.
Just I will start my case. Our patient is 65 years old, male, known case of diabetes, hypertension, CKD, with creatinine around 300. He had been transferred from other hospital due to upper GI bleeding for endoscopy. During his admission, was transfused with two packed RBCs and endoscopy shown non-bleeding duodenal ulcer with clean paste and treated with BBI and octreotide. Referred to cardiology due to his ECG changes and symptoms of heart failure. His ECG, as shown here, have LVH with STT changes, mostly related to his LVH or high voltage EKG. We did for him echo, and his ejection fraction shows 35 to 40% with critical aortic stenosis, Vmax 5.2 meter per second, mean gradient 75 millimercury, and his RV is normal with mild reduced ejection fraction with moderate TR and severe pulmonary hypertension with PA pressure around 65. You can see here the echo, the 2D echo with color. There is high turbulence in the aortic area, and the Doppler shows the high velocity gradient. Prior to his intervention, we did his evaluation. His STS score was 3.5 and Euroscore 2.2, estimated to have low to intermediate risk with comorbidities of CKD, recent upper GI bleeding, pulmonary hypertension, DM, and hypertension. So there was a discussion about the treatment option.
Yeah, Dr. Mubarak, let's have around the table. We're starting with Dr. Tariq. Dr. Tariq, so now you see the case and the presentation. What is your thought? I mean, the intermediate risk with multiple comorbid, you would like to choose for the patient, like going a surgical AVR or going with the percutaneous options?
So we always have these discussions with the surgeon in the room to avoid any bias. My own personal bias is that somebody who has a history of GI bleeding, severe renal dysfunction, low EF, would be a better candidate for a TAVI versus an open heart surgery. One of the challenges here is how you're going to work him up for the TAVI. The CT TAVR requires contrast. You have to look at the coronaries as well. These are things that you have to work through. But my own personal bias here is that I think this would be a good candidate for TAVI.
Dr. Hussein Amri?
I agree with Dr. Tariq, yeah.
Yeah. Dr. Ali or Dr. Traina, any other thoughts?
Yeah, I mean, the anatomy is going to be a big determinant. So whether there's high-risk features, so if assuming there's no high-risk features on the CT, and whether you're going to pursue a non-contrast CT and TE for annular sizing or et cetera, I'm curious what's going to be your approach. But I think the discussion has to happen after the workup.
Okay. Ali, any other thoughts?
I think TAVI is reasonable. Sounds like a sick patient with lots of comorbidities. The only other comment I want to make is the mean gradient is 75 in a patient with low ejection fraction, which basically tells you that the actual gradient is higher than 75. So it's a pretty tough case, and I think it's all about planning for this.
So already out of the back, you're having most of us, if not all, we're saying going with a percutaneous approach. So what have you done, Dr. Mubarak?
Yeah. So almost the same discussion have been conducted in our combined. Is not moving.
Next slide, please. Could you help them?
Yeah, and our heart team discussion, as mentioned from our colleagues, that the patient have recent GI bleeding. And he's considered a bit high risk with CKD, comorbids, even though his scores is low to intermediate score. So the decision and the heart team discussion was to proceed with TAVI. Honestly, we did for him the CT, it's a contrast CT, and which was bicuspid aortic valve with a fusion fright and non-coronary cusp. Type 1, and the heavily calcified valve with calcium score 3,252. His annulus areas shows 409 and perimeter is 73.2, diameter is 22.8, intercommissural distance at 4 and 6 millimeter was 22.8 millimeter. So he has a type of a tube sizing annulus and ICD, and his coronary height shows a good coronary height. It's around 14 in the left and 18 millimeter in the right coronary artery. His peripheral axis was great. So we were discussing what is our platform, is balloon expandable or self-expandable valve.
You can hold
to
here,
enter.
Dr.
Yeah.
Mubarak. So, Dr. Hussein, now we understand it's like a bicuspid aortic valve, reasonable access, reasonable coronary height. I mean, and he's like in his 60s. So we usually plan the second intervention at the first intervention. So how do you think you should plan this, knowing the CT and the echo in the background?
You know, since he's young, there's a possibility that he will need coronary angiography in the future and probably PCI. So I will go with a short frame with balloon expandable valve. Also, it's good in the future if he needs another valve, you can use self-expandable and a balloon expandable.
Dr. Tariq, will you, like, in the background of a bicuspid aortic valve, are you going to be like a pre-dilate or like, all comers, or this is specific this case?
So our practice is most bicuspid valves, we predilate. In this case, with a gradient of 75 and a very small area and heavily calcified valve, I would probably go with a predilation.
Dr. Trina, what about now the contrast issue with this kidney background? Any precaution going with, maybe try to minimize the dye or going with zero contrast, the trend? So
Yeah, and so I'll just back up a step. So there's a couple high-risk features for TAVR in this case. So I would have rediscussed before we went ahead, but assuming we did, because there's a very calcified raphe and there's a lot of leaflet calcium. If the surgeons still felt it's too concerning, I think we could still go ahead. But I think, we did contrast for the CT, obviously, so that was fine. But I think in this case, what our practice is, our average contrast is about 20 cc's. We use 50-50 contrast, mostly use positioning, puffs, don't take injections, and just do echoes. So a case like this, you can easily do with 10-15 cc's of contrast as long as you're using your pigtail markers and your anatomic markers rather than injecting.
Dr. Ali, what about, like, from your perspective, do you want to do the coronary upfront or like complemented the CT knowing the coronaries? Like, because we're always having this discussion, should we do the coronaries upfront, the TAVR, for example, or whatever, or utilize the CT since the patient is doing CT and go with it? So what is usually your practice or your approach?
So that's a very good question. I don't really do routine coronary angiography prior to TAVI in my practice, as long as we have a good CT quality to rule out obstructive proximal CAD. The other thing is, we don't really know how to manage coronary artery disease in patients with aortic stenosis. And I think we should wait for more guidance and guidelines in terms of, PCI. Is it going to help in terms of outcomes? Because we know that's not being shown to help in patients with stable CAD. Why would it show benefit in patients with AS? I'm not sure. My practice is, as long as the cardiac CT rule out proximal significant CAD, I usually just go with the CT.
Okay, Mubarak, show us what you did.
So as discussed, a relatively young patient, coronary access aiming to longer durability and possibility of redo TAVI as he's still 65. So the decision was to implant Edward Ultra with Resilia. So upon annular sizes, his valve was up to 23 millimeter valve. As you discussed, Doctora, we just mentioning, are we going to do coronary angiogram? We are not doing routinely coronary angiogram for.
Can we have extra 3 minutes, please? 3 minutes, please. Thank you.
Yeah. We are not.
Do we have the slides, please?
Yeah. We are not. We are not doing craniogram, and the procedure was crossed with the Safari extra small pacing on the wire. We did the pre-del with the 20 Zimit balloon, and we use the 23 Sapien 3 with the Resilia, and we close the groin with the Manta. This is, I guess this there's some AR here. Maybe this is the angio after pre-del. We pre-dilate. You can see in the balloon how is it tied. There's a myociding effect on the balloon. And this is the deployment. It was under pacing with the slow deployment. Always when we do aortogram, we see the craniogram. We can see clearly the aortogram is sorry, the coronaries are fine, and sorry, and the height of the valve, it looks 90 or 95.5. The gradient post procedure and second day, we are always doing this. Second day, 24 hours, it was 9, the mean gradient, without any paravalvular leak. Okay, thank you.
Thank you, Mubarak. Just final thought, for question for you. I mean, knowing that he had a GI bleeding, did you discharge him on any antiplatelets, like in this specific case?
Yeah, always we discharge them on single antiplatelets.
And for this patient in particular, you continue the same?
Yes.
Okay. Any other questions from the attendee? Any questions we have? Or we should move to the next? Okay, thank you so much, Dr.
you.
Mubarak.